Hi, my name is Pascal. I'm one of the hip and pelvis surgeons at the Lucerne Cantonal Hospital. Percutaneous screw osteosynthesis is the preferred method in fixing the posterior pelvic ring. A major challenge remains the intraoperative imaging, which can be hindered by weak contrast. In conventional S1 screw placement, surgeons must estimate the optimal inlet and outlet views by trial and error. But when the X-ray beam aligns tangentially with the structure of interest, absorption is maximized, resulting in a high contrast. The 3D robot-assisted imaging-guided navigation system enables swift switching between personalized inlet and outlet views, allowing for best imaging quality to prevent suboptimal screw placement.
Personalized angles are measured on the diagnostic CT scan. The outlet angle displays the paracoronal surface of the sacrum without symphysis superposition, guiding the craniocaudal direction of the screws. The inlet angle provides perfect visualization of the anterior cortex and the anterior-posterior screw orientation. The setup consists of the X-ray on a robot arm and a synchronized table. It is managed by an operator on a control panel. Two large screens show the acquired images with the planned screws as overlays. Let's begin the procedure in a 90-year-old female with a fragility fracture of her pelvis. To facilitate an efficient workflow, screw pathway planning on the diagnostic CT is performed while preparing the patient in the hybrid OR. This involves ensuring symmetrical alignment of the pelvis in all three planes and defining an auxiliary pathway to achieve the lateral view intraoperatively, which is essential to determine the optimal entry point for the SI screw as shown here. A stab incision is made and a 2.8 mm K-wire introduced onto the bone. The position of the K-wire is checked and corrected on the repeated X-ray controls in the lateral view. Once the optimal entry point is found, the K-wire is advanced into the bone with slight hammer blows. Then the C-arm is moved to the previously defined personalized inlet and outlet views to check the direction of the K-wire. Adaptations may be made. Then the K-wire is further advanced on the repeated X-rays in both inlet and outlet views to control for correct positioning. Once final position is achieved, screw length is measured, and the three cortices are drilled and the screws introduced. To check the snug seating of the washer on the outer cortex of the ilium, the C-arm is positioned anterior-posteriorly with a 20 degrees tilt to the ipsilateral side. There may be no tactile feedback due to osteopenic bone. Then a screw can be done on the contralateral side in an analog fashion. To increase pull-out force, the perforated screws may be augmented with PMMA. At the end, a 3D scan is performed. The position of the screws are checked and if needed corrected directly in the same surgery. Wounds are rinsed and closed with single stitches.
The patients are mobilized with full weight bearing with the help of the nurses on the evening of the day of surgery. For standardized positioning and collision-free movement of the robot arm, we recommend floor markings for all mobile devices. These sacroiliac screws may be combined with retrograde superior ramus screws, transiliossacral screws, sacral bars, or iliosacral screws on the S2 body. This technique is highly adaptable and may be combined with open or vascular procedures or may be used in the interdisciplinary treatment of metastatic bone disease. For more information, please check out our two recent publications. Thank you.